In our final section, we'll consider the implications of recent clinical data for the use of biologics in chronic rhinosinusitis with nasal polyps. So there have been some recent publications looking at new and emerging biologics in the nasal polyp field. Mepolizumab, the results of the SYNAPSE study have been published, and that showed significant improvement in both nasal polyp score and nasal obstruction measured on a visual analog scale at the endpoint of the trial at 52 weeks. Benralizumab has been presented very recently, and they've shown significant reduction in nasal polyp score between weeks 40 and 56. Tezepelumab, results of a trial in asthma have been presented, and in terms of reduction of acute exacerbations of asthma, the results are very encouraging. Tezepelumab currently is undergoing analysis in a phase 3 randomized controlled trial for nasal polyps. So we don't have any results for the polyps per se, but that seems to be working one step up on the inflammatory cascade. So now we have a number of different treatment options for patients with severe chronic rhinosinusitis with nasal polyps. And an extra challenge for physicians will be better understanding how these will all fit into the clinical pathway, and in particular, which biologic to choose for which patient. How do you think these new and emerging biologics will really complement the field that we already have in terms of dupilumab and omalizumab? Where do you think they will sit, and how will we choose between them, Martin?
Thank you, Claire. So I think that where we are is as we are in the biologics world for asthma, where there's a number of different medications, and we all have the feeling that each one must have a unique benefit in one situation. I think that this is probably the case. We've had a decade of clinical experience with mepolizumab and omalizumab used in asthma, and we've seen patients with asthma and nasal polyps come through. Now, clearly, these haven't necessarily been category killers in terms of managing nasal polyps, but we have to understand this is when patients were selected for asthma, not for polyposis. So as we delve into the use of the biologics for nasal polyps with associated, usually moderate asthma, we have to look at the results there. The results in the trials are difficult to compare one against the other because they use different measurements. Certainly, all of the medications meet their endpoints in this particular patient setting. Clinical experience that we've acquired over the past year, though, in biologics prescribed for nasal polyps has mainly been with dupilumab, where the success has been very good. In clinical trials, we've also had good success with benralizumab and mepolizumab, with the possibility of a responder phenotype within mepolizumab. But again, we don't have any differences identified between the medications yet.
Yeah, I think my experience has been very similar. Dupilumab seems to be better in terms of particularly restoring sense of smell for patients with nasal polyps. And that's often a big driver for them seeking secondary care. And I think perhaps that's one of the most important symptoms for the nasal polyp patients. In contrast, my pulmonology colleagues seem to have a preference for mepolizumab and benralizumab in terms of the effectiveness for asthma. So I guess for many of these patients, it will a little bit depend on which is more severe, which is the bigger driver for treatment, because we're not just treating one condition in many of these patients, and we need to consider the bigger picture as to which will work best. But it's really interesting that what may work better in asthma may not work quite as well in the nose, when we've talked a lot about how they share the same pathophysiology. Klaus, have you got any feeling as to why the response in the upper and lower airways might be different? What's driving the differences, and how we can really use that to decide which is the best biologic to choose?
These are extremely good questions. And, we learn about biologics at the moment, realizing that there are differences between the upper and lower airways is extremely interesting. Of course, what I understand from asthma, for example, is that the most important thing in asthma is exacerbations. And these exacerbations are most likely accompanied by changes in the eosinophil number. So the focus here is clearly, on the one hand, eosinophils, on the other hand, the exacerbations. Now, in nasal polyps, we have no exacerbations unless there is an infection, and that it's a germ. that comes on a very weak mucosa, and that is why it is that these patients have frequent infections. But it's the disease itself is not exacerbating, and we do know that the eosinophils are an important part of nasal polyps, but they are not, let's say, the most or the all-explaining part in nasal polyp disease. In other words, if you treat mepolizumab with benralizumab, you treat the eosinophils, or with omalizumab, you treat the IgE, or you have an access to IL-4 and IL-13 with dupilumab, you are actually looking at different targets.
Martin, in your experience, are there any markers? We know that they target different parts of the pathway, IL-5, IL-4, 13, IgE. For example, does the IgE level necessarily predict the response to omalizumab? Because my understanding from the trials at the moment is that they don't really help us choose which of the biologics to go for in the way that you might expect looking at all the nice diagrams of the inflammatory cascade.
Obviously, we have something left to learn about IgE, because the past 20 years of looking at IgE have shown it to be a very unpredictable marker. Very interesting, but not so useful on prediction, which was the interest of eosinophilia. So one of the ways that you do end up selecting a biologic is mostly through a trial and error process that's done in collaboration with the referring physician. For example, many patients will come in already treated with a biologic, which may be giving them control of their asthma. But when you look and you see, oh gosh, we don't have upper airway control here. Maybe it would be beneficial to get some airway control. Let's change the biologic. Then we can discuss with the referring physician among the remaining options, which ones could be tried. And ultimately, what you'd like for success would be to control the entire airway. We've been discussing the whole airway concept for a long time. Now it's time to put our money where our mouth is. And in my mind, appropriate respiratory control is both upper and lower airway control. So we will cycle through the different biologics until we reach the desired endpoint.
Now, Klaus, you've got quite a lot of experience of patients switching between different biologics. Have you found success with one biologic when a different one has failed? Is there anything to guide how to switch, or really is it just trial and error? And how long do we need to continue that trial before we decide that that approach isn't working? What's our endpoint to decide to stop or change?
I would always give a biologic some time. I do think we may see something in some patients after 4, 8, 12 weeks, but we should not decide that a biologic does nothing in a specific patient, which is possible, unless 6 months time has been given. The endpoint would be change in nasal polyp score in my eyes, or change in polyp mass, also linked to a change in symptoms. And I would think a sort of a 6 month period is great. I think we would come rather from the other side, would say, well, okay, what is the most likely to work in that patient? It is a type 2 immune reaction. The eosinophils are involved, IgE is involved. So you can make your choices there. And certainly IL-4 and 13 are involved in these patients. So you actually look at the study results, and probably in the future more also on results from registries showing that in real life these patients and what percentage of patients actually reacts to the drug and answers to the drug in a positive way.
And Martin, coming back to your question, you said that there's no one size fits all. But if we look at those diagrams in the cascade, we see IL-5, IL-4, 13, IgE, but one step above them in the ladder, we have TSLP, IL-33, IL-25. Is that really the way to go? Is tezepelumab, or an anti-IL-33, is that going to be the answer? Is that the way to get the one size fits all? What's your feeling?
Well, an anti-TSLP antibody is showing effectiveness in asthma in terms of reducing asthma exacerbations. The endpoints in polyps haven't been studied as of yet and haven't been released. In atopic dermatitis, there is no development program for anti-TSLP because it did not succeed in phase 2 trials. So we cannot assume that in CRS, with its high bacterial burden, that anti-TSLP will be as successful as it is in asthma. As well, in terms of the other alarmins, while IL-25 presents an intriguing new target, IL-33 is a target that hasn't really worked so far, so that these key cytokines may be too upstream and either have effects that are too pleiotropic or be compensated by redundant effects from other systems.
And I think that word of caution is really important. I'm very excited to see the results of the tezepelumab trial. In many ways, I hope it will bring the best of all of the biologics that we have together and increase the responder rate. But we only have to look at the trial of dexpramipexole in nasal polyps to know that, what we assume might be a wonder drug may not work. Now, dexpramipexole completely depleted all of the eosinophils in polyp tissue in Tanya Laidlaw's study, yet the polyps didn't reduce in size at all. So, that's really challenged our assumptions on the role of eosinophilia, for example.
And in perfect fairness, mepolizumab does not wipe out eosinophilia completely, particularly in tissue. And this may have a role in host defense.
So, it's a really exciting time to be working within the field. I share your view that I think we're both unlikely to be out of a job as surgeons, but it is a really exciting opportunity to really get to grips with the immunology and the medical side. And of course, to really work with our colleagues in allergy and in respiratory medicine. Now, one of my patients told me that he felt like the rope in a tug of war, being torn between an allergist and a respiratory physician and surgery. And he felt that everyone was pulling him in different directions, recommending surgery or biologics. How moving forward do we make sure that we really all work together and that the patients see that we're all on the same team? Martin, any sort of closing thoughts?
My personal take is that the patient will understand the quality of care that is offered within otolaryngology as the otolaryngologist becomes the treating physician for the polyps and manages the consultant's advice accordingly and appropriately in a coordinated fashion. This requires understanding and respecting what your consultants do and having them understand and respect what you do. And often you need to dispel a certain amount of fear-mongering regarding surgery. Often, either structured or informal discussions around individual cases help you explain to your fellow clinicians how you work and let them understand your thought process, which is different from theirs, but perfectly valid. And as we come to an understanding of how we work as physicians, then we can start working together to offer the patient best care. But at no point in time should the patient feel anything than a warm, fuzzy blanket, just dedicated to making them feel the best possible. I'm very sorry to hear what's reported. That's not the goal of the effort.
Well, I think our patients feeling a warm and fuzzy blanket around them is the perfect way to end our discussion. So we've really talked about some of the challenges in diagnosis, but hopefully given tips for those outside of ENT as to how they might identify the patients with nasal polyps. We've talked about the challenge of managing patients with severe disease and that cycle of surgery and oral corticosteroids that many of our patients in the past have found themselves in, often with long periods of poor disease control. But we've also talked about how a much better understanding of the role of type 2 inflammation and that unified pathophysiology with nasal polyps and asthma has really led to huge improvements in the possibilities of caring for these patients. And I think biologics will really play a major part in the management of nasal polyps in the future. I'd really like to thank Martin and Klaus for joining us this evening and the really interesting discussion and the views that they bring. And thanks very much for all of you for taking the time to watch us. Thank you.
Thank you.
Thank you.